is approval of the minutes. You should have a copy of the minutes on your table. So I hear an approval, second. Any dissent? Hearing no dissent, minutes are approved. As the officers report, treasurer's report from Dr. Mary Wynn, bank balance as of the 23rd is $55,629.71. In terms of announcements, if you know any students, we do have some student scholarships open still. So please let any students that you know that there are scholarships to apply for on our website. And then our next meeting will be the June 24th meeting. We'll be back here. We're going to start a little early at 6:30-ish. We're doing our annual resident scholarly activity where the residents from our 3 local residencies are going to present their posters' scholarly work. And so now for tonight's program with Dr. Henderson, he is doing thoughts on informed consent and end of life, the nexus between autonomy, substituted judgment, and beneficence. Very, very interesting. One required.
All right, just to get some admin stuff out of the way. Thank you guys for joining us today for the South Texas Regional Family Medicine Grand Rounds. Our educational partner today is the Texas Academy of Family Physicians Alamo chapter, of course. And our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. Thank you in advance for being attentive to the presenters and engaged in the session, for registering for CME credit for each session, and for completing and submitting a session evaluation form. Today is May 27th, 2025, and you can register your attendance and claim credit using the CME credit via text system. Today's session code is 1009-6276. So you just text attend 1009-6276 to the number on the screen to record your attendance. And this credit would be what you'd use for your ethics submissions. You must register for each session by midnight in order to receive CME credit. AAFP members can use your AAFP login and claim credit for this activity online at the link on the screen. And this live activity, the South Texas Regional Family Medicine Grand Rounds, is reviewed and is acceptable for up to 1 prescribed credit by the AAFP. And physicians should claim only the credit commensurate with the extent of their participation in the activity. The ethics credit has also been applied to the AAFP CME portal as well. Our Grand Rounds address the following nationally established physician core competencies: the Institute of Medicine core competencies, the ABMS ACGME competencies, and the AAMC competencies. All right, and I'll hand this over to Dr. Henderson.
I have to smile because it really is a pleasure to see a lot of new and old faces. So I'm not going to wax too poetic, but I can. First, I have to say hi to Dr. Martin. Again, I would not be standing here if I had not met Dr. Martin 15 years ago. I really appreciate all he's done to have me involved. I am a pulmonologist, critical care doctor. I'm one of those awful people and interns. Oh my goodness. But he and the director, program director at Christus at that time, Todd Timms, had the insight to say, we would like someone like you to work with our family medicine residents. And they invited me on this journey about 15 years ago. I think I spoke at this meeting 10 years ago on a different topic. So every once in a while I drop in here. A lot of other people here who I know and I appreciate. They don't remember, but I also met them 10 years ago in the same, situation, and they obviously have a connection with a Christus residency as well. Many former residents, I appreciate every one of you, and current residents. So, how did I get convinced to do this? It's your esteemed president, Dr. Mayfield, who said, "Hey, please come." And so I'm glad to be here. And besides requiring an ethics hour, I decided that I'm going to talk for a while. We're going to talk through some basics. I think in some ways there's a requirement. I've done this in ethics. There are certain requirements that you really are supposed to. And then we'll talk about, I think, something that's really, hopefully, that's really about who you see and how you practice. And I want to spend a lot of time talking about the idea of autonomy and how it implies in both ideas of informed consent. And because many of us take care of the elderly and those who are unable to take care of themselves, that have substituted judgment are identified us. And I think it's really important to talk about those issues. Those are things I think each of us probably face every day, whether in the hospital or in our clinics. And so we'll go through those things. So I'm going through some of the basics. I hope I don't bore some of you ethics experts here, but I think it's important. And then we'll kind of delve more into this. And as the residents are going to be, please feel free to wave at me and ask the question. I have no problem with that. If I don't have the answer, I'm sure someone else here does, because there's a lot of smart people in the room. So, prologue. Physician treats with words. Within the physician-patient social system, the patient is moved by fears and other sentiments. These are modified by the physician's words and phrases. Physicians dispense not only medicine, but words that influence medicines, and all by themselves that affect the patient more than the medicine. I think that, oh, I went too far, sorry. I hit the wrong thing. I hit the touchpad, I'm sorry. It's important to recognize that, I think in this august body, it's important to realize that you do a lot of what you do. The healing you do is speaking to your patients. It's being a part of their lives, of participating in the crucial decisions of their lives. In that way, you apply moral and ethical judgments every day with almost every patient you speak to. So what we're going to talk about, some definitions, the scope of ethics in your medical practice, in case presentation, and then some discussion. So again, ethics is kind of based on the concept of moral principles, a code of behavior, what we think is good, what we think is bad, what we think is right, what we think is wrong. Now, arguably not all of us agree on every of that topic, but in medicine, because it is such a unique field, there has been a predominant compliance or a coming together of ideas of what we feel is good and bad, right and wrong. We have an accepted value system, and it is the basis of medical morality. And it's what we believe is right and wrong. And then we apply it to ethics, and that is how we reflect on what we believe is right and wrong and how it applies to each other, and particularly to our patients and their families. Again, as I said, these aren't universal. Not everyone has the exact same agreement. Obviously, many of us may come from different cultures that see things differently. But when we come into this as a joint medical practice, we tend to have to come together in some form of agreement in where we're going to go. So what are we saying? It's not feelings. It's not religion. It's not following the law, although the law has impact. It's not following cultural norms, because those change with time, right? And it's not science, but it's deeply involved in the application and how we apply science to each other and to our patients. So all these things affect the implementation of ethical treatments and judgments, but in themselves are not ethics. Let's talk about the idea of law and ethics together. They're related, but not the same concept. So laws are mandatory, right? We have a legislature and we signed into law, and if you don't do what you do, the big boogeyman, the sheriff or the police will come and pick you up. So all citizens have to adhere to laws, right? Ethics relate to our morals and how our morals even apply to law, but it's kind of complex. It's an evaluative place where information and values kind of come together, and we kind of have to formulate an agreed path, right? Bioethics takes that same principle and places it in the realm of both biomedical science and medicine in and of itself. How we apply, again, treatments, how we apply discussion applications, how we reflect on what we should research and what we shouldn't research. That's when we come to the idea of bioethics. So in our society, which again, many cultures, ethnicities, backgrounds, we can misunderstand each other, okay? Even in the medical profession, we can misunderstand each other. So we have to accept that that's part of it. But when we come together in healthcare, we come together in organizations like this, like the Alamo chapter, like AAFP, like other organizations, and we have a shared experience, right? We talk about things, we meet in conferences, we meet in discussions, and we say, what is ethical for what we do? Same way we may have a guideline for treatment of hypertension or diabetes. We say, hey, how do we apply these therapies effectively and appropriately for each patient? And again, how does it impact their families and actually the society in which they live in? So it's important to find that understanding. And medicine probably, has a very good background and understanding on what we do with that. So we know we're diverse, we find common ground, we discuss it, we debate it, we apply science to our feelings and all that stuff, and then we come forward with recommendations and basis for agreements. We develop value constructs that then actually organizations like the AFP and others actually hopefully, and TMA and other things, hopefully use to actually even influence law, right? So our practice of medicine doesn't go against the institution of the law. So let's go back to early principles, right? Hippocratic Oath. Believe it or not, there were other oaths other than that of Hippocrates, but that's the one that has stuck through the years. What was it about? Prescribing only beneficial treatments. Beneficence, you'll hear that word again. According to your own abilities and judgment. Even in that time, Hippocrates understood that not every physician, not every caregiver was equal. We have different levels of understanding, training, and knowledge. And what we are responsible for is to do the best we can with what we know. And when we don't know something, we're also responsible to try to defer or refer to someone who knows more, to refrain from causing harm. And we'll go back to that over and over again. We are not here to hurt people. We're here to help people. And Hippocrates says we should be exemplary. We should be exemplars for our society, in both our personal and professional lives. We're held to a higher standard to do good and avoid evil. Now, in that time, we weren't supposed to assist suicide or abortion. We were supposed to make sure only surgeons do surgery. That may be a barber surgeon at that time or a dental surgeon at that time, because that's who did surgeries at that time, but whatever. And again, not to harm. And not, even at that time, not to seduce patients. Even at that point in time, that was discussed. And again, the idea of confidentiality. It far preceded HIPAA or anything else. The idea that when a patient comes into your presence, that is a sacred trust that you're developing with that patient. And that we have to honor them and honor who they are and what they believe in and what they care about. And again, and since then, many adaptations, variations of the oath have come about, but these principles kind of flow through the majority of those variations. Moving now to the last 80 to 90 years, as we went through 2 world wars, a lot of bad things happened in the world, and we recognized that maybe things weren't great. So the World Health Organization, which was started at, after the United Nations was formed, they also, as a different body, decided to societally come apart with some ideas of what is moral. And I just want to point to the Universal Declaration of Human Rights that was published in 1948, which not everyone agreed with. And in fact, the United States has never signed on to the Universal Declaration of Human Rights, by the way. But that there is an inherent dignity in man. And in man, I mean, obviously, human beings. And that we have equal and inalienable rights as members of the human family. And this should serve as the basis for how we perceive each other, the concept of the person, our rights for dignity, our equality as human beings. And that implies when you are in a less than aware state or a less than capable state, when you are a patient and you're depending upon some kind of authority, like a physician, a nurse, a therapist, that person deserves the honoring and the recognition of the dignity they have as a human being. So what's owed to a patient as a human being by us, by the state, kind of has been formed by these thought processes. And since then has been, I think, not moderated or changed, but further explained and discussed in the Helsinki document in 1964. Everyone has heard about the Belmont report that dealt with human research in 1978. In 1991, the Federal Self-Determination Act. You can delve into these in detail if you want to. They each kind of apply to a certain way of how do we look at each other as human beings, especially in the face of medicine and medical research. So the core topic, what are the basic principles when we talk about medical ethics or bioethics? Beneficence, that is, we are here to do good. The corollary of that is the second, right? Non-maleficence. We are not here to do bad. We are to avoid doing bad at any point in time. But wait a minute, if I take a knife and I cut somebody, isn't that kind of bad? Well, it is, but if I'm cutting out a tumor, or if I'm repairing an injury, all of a sudden the concept of non-maleficence becomes beneficence. So all these, obviously, principles have adaptation and understanding within the course of each other. Autonomy and respect, and we'll get back to that because we will spend probably the majority of this, the end of the talk on the idea of autonomy. That is going back to the Declaration of Human Rights, going back to even the Hippocratic Oath, that we are all people with equal and unalienable rights due to our humanness and who we are. No matter who we are, where we come from, what we believe, we are in and of ourselves worthy of respect. Since then, there have been a couple of these ancillary, and those are the four basics for a long time. There are a couple of ancillary corollaries that have been placed in, the idea of privacy and confidentiality, which you also heard in the Hippocratic Oath, but has now become more a forefront in the idea that part of ethics is respecting, and part of autonomy is respecting the idea of privacy and confidentiality. Truth-telling. Although, doctors are no longer the most respected profession in America. We were for many, many years. Part of it is because maybe we forgot that above all things, we should be truth tellers to our patients and to their families. And then the idea of preservation of life. And this is in and of itself goes to a whole concept of what does that mean? How is that defined? But I will go back to the point that in the end, we're here to serve our patients. We're here to help our patients. And essentially, it does come back to our understanding and discussion of who they are and what they do. Again, anything, questions or comments, please wave. I'll stop. So I want to spend most of the time on this idea of autonomy, because I think in my dealings in the ICU or in clinic or telling people that have lung cancer or whatever else is going on, I find this is kind of where 80% of the time the rubber meets the road, is helping to understand or helping to concept of essentially what is it that's good for this patient, what does this patient want, respecting their wishes is really almost the basis of the majority of things we see and the majority of conflicts we see in ethical discussions. So it is the right to participate in and make decisions concerning their medical care and to accept or decline offered medical therapies without undue influence. And this obviously, in the NW references, there's a finding verse in 1914. And I will tell you, this is a fairly new concept. It's a concept of the mid to late 20th century into the 21st century. If you go back in the 1800s and 1700s, this idea was not prevalent, even though it went back to the Hippocratic Oath. We, as physicians and medical professionals, not we, but our ancestors, tended to practice godhood in some ways. We did for our patients what we thought was best because we didn't feel they had the knowledge, education, or understanding to make input. And I will guarantee each and every one of you deal with patients each and every week that you wonder if their medical understanding and knowledge is adequate enough to understand what you're telling. So that problem has not been surrendered, but how do we cope with it? How do we deal with it? How do we inform and teach our patients so that we have their joint participation? So again, so in 1914, this was one of the first lawsuits on record that dealt with this issue. And the finding of the court at that time was every human being of adult years and sound mind has a right to determine what should be done to their own body. Now, for us, this is basic thought. But if you go back 100 years, it was not. So self-determination, they have the right to act independently no matter what we advise them or what we believe should happen. So it comes to the idea of informed consent. The patient has the right to what? To be informed and to then make a decision. This kind of is part into the ideas of capacity. That means that patient's ability, disclosure, informing and teaching and giving that patient enough information and hopefully wisdom and knowledge to where they are able to interact in their own care. And then the voluntariness, no undue influence, no forcing of patients, no threatening, no if and then, no quid pro quo type treatments of patients. So what about the idea of capacity? Again, the ability to do a task. And again, we all know this now, we've been talking many times, it's not competency. Competency is a legal, determinative, psychiatric, and psychopathology decision-making. But people can actually not be competent, but still have capacity to understand what we're telling them. It's task-specific. It's judged by the ability to express that they understand what the outcomes of their decisions will be. And again, a person can have capacity to make a medical decision, but not other legal, financial, other decisions because they can't understand it. Frankly, I still can't understand my taxes all these years later. Anyway, and again, So having that decision-making capacity, again, does not equal competence. That's a legal judge, i.e. determination. But we deal with capacity. Disclosure, again, you have to give patients all reasonable information and ensure understanding. And so it's a reasonable person standard. So I'm going to do a procedure on this patient. And I know that there are 200 possible adverse effects of this procedure. Do I sit down and explain all 200 adverse effects of this procedure? Well, I could, but I would fall asleep by it. Basically, would understand it. So what do? We look at the most common adverse events, the most dangerous adverse events, and we discuss with the patients. These are the risks we tell you about. Okay, why? Because that's reasonable. You know, I'm not going to tell you that your toe will turn orange if one person in, you know, a medical journal from Antarctica had, you know, bottom line is that, you know, it's got to be reasonable, right? And the CMS guidelines say informed consent requires a patient to have a full understanding. Notice that, full understanding. I was like, okay, of that which he or she has consented. An authorization from a patient who does not understand what he or she is consenting to is not informed consent. An authorization from a patient who does not understand what he or she is consenting to is not informed consent. I think you understand why I'm emphasizing that. I think it's very important because I have seen this violated. I've seen this violated. And I think as responsible physicians, certainly if those patients are in my care, I do my best to prevent that from happening. And I think I'll say we, especially as primary care providers who take care of our patients, who actually are, I think, in many ways, the best advocate for our patients, I think that's our responsibility as well. Voluntariness, being free of undue influence. So again, simple, no force, no coercion, but at the same time, when patients are in pain or when patients are psychologically in a point where they actually at that point really have capacity to voluntarily agree or disagree with the procedure? And that's something you as physicians have to sort out and determine to the best of your ability. Okay. Again, there's the idea of implicit versus explicit. Again, if someone shows up in the emergency room and they're unconscious, EMS brings them in, we assume, right, an implicit idea because they were brought in that they want, I'll use the term, quote unquote, everything done, right? But when someone comes into your clinic and they call your clinic, they make an appointment, we assume it's implied that they want an examination. That they want, I mean, does anybody get consent signed to do a CBC or CNT? No, we assume because they came in that they wanted to use your education, your understanding to be able to take care of them. So these are all low risk, right? Never no risk. Again, nothing we do is zero risk, but they're very, very low risk. Now, once what we do becomes a little riskier, it moves from the realm of implied and versus explicit or getting direct permission. Personal exposure issues, moderate to high. Like again, if someone's going to get a pelvic exam, normally we're not going to but we directly ask them, I think you need a GYN exam. This is what we're going to have to go through. I think it's best for you. Clearly, you have the right to refuse that. But I think to find what's going on with you, this is what we have to do. Those kinds of things where we need to get direct confirmatory permission to move further in treating that patient. So the idea of risk, benefit, cost, options, non-treatment, course of therapies. If those become an issue, we need to discuss that with these patients. So again, you transmit the information, you have a point of discussion with the patient. You have to assess if they understood or not. There's no one else in that room usually with you, unless it's a more complex procedure, you have someone witnessing, but you're the one because you will be doing the action. So it's your responsibility to assess, does this patient really understand what I'm saying? I'll go up and meet with, talk to much I divest. We had a lady, some of my residents know who I'm talking about, who I had to reintegrate for the third time on Friday. And the discussion was, did she really want this? Is this really what she wanted? And as she was kind of going downhill, trying to get the family in, we talked to her for probably 50 minutes, trying to be comfortable. Because initially she was saying, no, don't put the tube in me at all. But for me, And this was my assessment of understanding. I said, but do you understand that we do not do this? It is almost guaranteed you will die today. You know, and I'll say this, she could not convince me that she understood that. And look, I also had 2 or 3 other residents in the room with me, and she could not convince them. Okay. So at the end, so honestly, I kept, hate to admit it, I hope I wasn't coercing, but I kept saying, but I'm not sure that's what you want. And then she said, yeah, go ahead and put the tube. So, you know, it really comes down to, in the end, when we get to the end of this lecture, we talk about ethics, it really comes down to, in the end, your heart. Do you feel you're doing the right thing for the patient? You know, are you comfortable with, if you even feel like you're not doing the right thing for the patient, it's the patient that's making that decision, understanding the outcomes of that decision, okay? And then if it's a, you know, voluntary agreement, and then obviously you have to document that consent, right? So remember I said law kind of comes into this? Well, it does. And Texas has always been kind of a trailblazer in everything. And Texas really had one of the first, and I'm gonna go to the idea of end of life care, and we'll talk about a couple of things as well. There actually was an act in 1977, I'm trying to remember the name of the act, that first broached this concept. And it was one of the first in the country, but it was somewhat confusing. It had some mixed laws. So really the first one I'm going to talk about, because actually it's the first one I practiced under, is really the Texas Advanced Directives Act, or TADA, in 1999. Competent adult may set limits on their own medical care by directly expressing a choice, getting a directive, appointing a medical proxy to make a decision. And they would give a window to the value of the patients and inform conditional care dependents. So it also, luckily for us, also had liability shields built into it. That is, if we follow these rules and we do it the way it's laid out, that a physician, there was no grounds to sue a physician on the idea of either malpractice or adjudication of the patient's wishes. It doesn't mean you couldn't be sued. It meant that there was no ground in law to do it. It also defined or described inappropriate care. It had the issues of medical futility kind of in it, not directly spelled out. And that was the first place where Texas hospitals were required by law to have ethics committees. Patients, families, if there was some point of contention, an ethics committee would need to be engaged. They would get a 48-hour notice that the ethics committee was going to meet on their care, and that if the ethics committee decided essentially in a manner that was against the wishes of the patients, and it described all these policies in the law, can't go into detail, that the patient was given a 10-day opportunity to either engage other care, first thing to appeal, to gain other care, or have the patient transferred to another physician. But it sounds great, right? It sounds great. Well, all of us know they had lots of problems, especially all of us in intensive care and dealing end of life had lots of problems throughout history. Lots of difficult cases. So I'm not going to go into those in detail. We can talk about them if someone wants. This has been recently revised. It was initially attempted to be revised. Actually, this law was eventually also intended to be revised. And parts of it that was the original was there, Governor Bush vetoed. Because actually the parts he vetoed they felt would have given physicians too much authority and too much power at the time. So again, but there was a revision finally pushed through in September 2023 after 3 or 4 years of very strong push from legislators from both sides of the aisle as far as more power to the patient, more power to the physician. House Bill 3162, again, going to the idea of inappropriate care and medical futility. They changed the way ethics committees are handled now, which makes it actually a lot more difficult, to be honest with you. Now you have to give patients' families 7 days notice before you make any decisions that might be contrary to their wishes. Now they have a 25-day exemption before facility can give them a chance to appeal and everything else. The de facto effect of that bill really means that the idea of medical futility has pretty much gone out the window in inpatient care in Texas. You might as well, I saw people say, let's have an ethics committee on the idea of medical futility. And I said, 99% of the people you talk about, honestly, will die before you ever get to the end of this window. besides the issues and everything. Now, should we meet and discuss with the family and find out what the problems are? What is a good way forward? Those things should always go in. And really right now, that is what most ethics committees do now. They don't really push some agenda or anything. Now we say, okay, what is the best resolution for this patient and their family over the next 3 to 5 to 7 to 10 days? That's what the effect of this law, this change has happened. Again, also you can't consider any pre-existing disability. You literally can almost only discuss the actual acute insult to the patient and its effects on that patient. It's an interesting kind of description. That's up for debate of interpretation. But frankly, most of us don't even deal with it because the ramifications of the law are so broad, it's really not worth it. And again, now patients can actually literally re-engage legal counsel up front as soon as this becomes, and can actually bring in 4 other personal advocates to these discussions, including other physicians and attorneys. It's become so difficult to push that in that realm that I don't even use the word futility anymore. Period. It's been eliminated from my vocabulary. Okay, I don't even use that word anymore. And again, with this, there were changes in the DNR process in and of itself that. I mean, I think the only thing that's worth mentioning is that I'm still astounded that if a patient tells me they want in a hospital verbally that they do not want to be resuscitated, they do not want to be intubated, I still think 2 witnesses, including one of which who is totally unassociated with anything on God's earth in the hospital. But if the patient is unconscious, and a family member who is their substitute judgment say something, do that. It's kind of bizarre to me. I didn't write this law, but it is what it is. You know, why I can't take the verbal word of someone who I feel has capacity without having all this additional. But anyway, that's the way the law is written, right? So again, also what happened about the same period of time is that they formed the Texas Medical Disclosure Panel. So many of you may have seen, especially in inpatient care, how medical consent forms have changed in the last 2 years. They were already beginning back in 1999, but it's changed again. And that there's a panel that determines, what must be disclosed. The minimum that must be disclosed to patients on certain procedures. There's 9 members, 3 lawyers, 6 physicians, elected by the Commissioner of Health. It lists A and B procedures, and essentially those things describe what you can disclose. I can read through this important, but the point being, you have to disclose to a person authorized to consent, risk and hazards, and in writing, you have to sign by the patient, authorized, consent, and a competent witness. This is really complex, it's legal jargon, but the bottom line is that it really goes into detail what it takes to get informed consent, especially for surgical and advanced procedures, because there's a whole list of those. And also, I will point out that failure to disclose risk and hazard shall be admissible in evidence and create a refutable presumption of a negligent failure to conform to duty, but failure to disclose may be found not to be negligent if there was an emergency or for some other reason it was not medically feasible to make a disclosure. So the point being is that they've now reenacted the idea of negligence if you don't appropriately disclose what they have told you you have to disclose. So I think I was going to do a little different, but I may have mixed this up, but I'm going to go here in the fast face of this. Many of these times we're dealing with this in patients who do have a lack of capacity, and we're dealing with surrogate decision makers. The idea of substituted judgment, that using them in a shared fashion to determine what the patient would have wanted in this decision. And again, that's the most important thing. That's the place many of us get to with our patients and their families. Our patients who have Alzheimer's, our patients who are debilitated, we're dealing with their family members, and we're talking to them, and we're trying to determine what this patient wanted. And the hope is that a family member who's known them for 5, 10, 20, 30, 50, 80 years would have an understanding of that patient's moral and ethical values. That's the hope. It doesn't always work out, but that's the hope. Again, not what they would want, which is what we deal with all the time, or even what the physician would want, but what we think the patient would want. And it can be difficult. Goes to the idea of respect of patient, for a person. So when I'm discussing this with patients, I really do use the idea of life stories, narrative stories. What does this patient like? What do they want to do? If I have a man who hunts and fishes, he hasn't been a doctor in 40 years, and they're dying, near students, and I know that the best hope for this patient is to be in a nursing home debilitating for the rest of life. I spent my time saying, is this what Joe really would have wanted? He spent his life hunting, fishing, being outdoors, doing stuff. He never came to a doctor. Is this what Joe really wanted? You know, those kind of things, trying to find out the narrative of their life and what it was they believed in, what they thought about. Did they have a religious belief or did they not have one? Did they look at things one way or another? The idea to find out what that patient really wanted. And it is in the eye of the beholder. So the best way is to get everyone on the same page and begin discussing this patient's life from that perspective. And then this idea of the best interest standards, the idea of community norms, you know, what's just, which is a hard thing, what's equitable, that's hard to discuss. So when we look at these surrogate decision makers, you want to think about the idea of what would the patient have wanted, what's respectful for this patient, and there is a little bit of what's best interest for the community. And that, in my mind, that is the family in most of these cases. What is the best interest for the family? Not really financially, but really emotionally, spiritually, you know, for them. And that helps you avoid extreme or inappropriate treatments if you can break it down to that point. So I know you probably can't see this. This is a little flow sheet. This is actually from the law. If like a center for treatment for adults, if patient is the first line, then a guardian or person has a medical power of attorney, then it's the spouse, then an adult child with consent, or all other adult children, the majority of reasonably available adult children. It goes on the hierarchy of substituted judgment. Now, to withhold or withdraw life-sustaining care, again, the patient is always top, right? And then medical power of attorney, then the spouse. Those are kind of the same. But as you move down, it becomes now the majority of reasonably available adult children. Okay. That's interpretive, right? Then it goes to parents. And then it goes to nearest living relative, that third cousin on your mom's side, if you can find that person. And then later it gets really tight, but it talks about friendship and social discussions and everything else. So that's what we use when we're trying to discuss care in a patient who does not have an advance directive. Obviously, in this setting, my goal is hopefully that all of our patients have advance directives. We're looked at it, and they don't. I know that. I know that not all my patients have advance directives either. I know that, but that would be a goal that they would. So we would know, or at some point in our care of them, we would have a discussion as far as what they would want if they were incapacitated or they were approaching end of life. I know it's not easy, but that would be the hope. And then again, we would have that answer, and they would legally form an advance directive, an MPOA, forming their healthcare proxy. So I bring this up really because all of us have dealt with this and the fact that, unfortunately, especially patient families and patients themselves have an unrecognizable expectation of what medicine is. So I am one thing, I was who saw the Pit this year, that miniseries. Although it's still not perfect, it was probably the most representative series I've seen, and I've watched all of them. And that it was very realistic, showed what medicine was like, showed how bad things could be, how people do pass away and die. Because most TV shows don't do that. So we have the Grey's Anatomy, Chicago Hope effect, and called deformed consent. So look at, going through ER, Chicago Hope, and rescue series back in the 90s, 77% of people who were arrested had ROSC. So they had return of spontaneous circulation. 77% of people who coded had return of circulation. 67 survived to discharge with function. Man, I wish I was that good. Grey's Anatomy, almost 70% had ROSC, and 72% survived to discharge. Again, with functionality on the TV shows. Huh? No. If you watched all the shows, what happened, the patients on the show, the people who had arrest or codes, that's on the show. 70% of people survive. 70%. So that's what the public expects. You are miracle workers. I mean, I have a 7 in 10 chance of surviving. So do everything for me. Please save my life. Doesn't matter, I have 4 cancers that are widely metastatic. My EF is 20%. My automatic defibrillator stopped working yesterday. No, you can save my life. And that's what patients and their patients' families expect, because this is what they're taught through TV. This is what they expect. And again, this is a great study. They actually interviewed a bunch of surrogates. 72%, they expected that their patient would survive any cardiac arrest. 72% of those patient families. And that's in hospital arrest, let alone out of hospital arrest. So now, they also surveyed the patients who actually had advanced directives. That meant they had talked to their primary care physicians or their specialists about their outcomes and behaviors. Now, even with that, only 19% of them had a real accurate perspective of what the prognosis was. So that's even now in patients and families who actually have gotten advanced directive. So we see it all the time. Someone who's in hospice or has an advanced directive, they come into the hospital, they come to ED, and they revoke their hospital. They revoke their advanced directive. Why? Because they think you're going to save their lives, make them better. And honestly, we do what? Not 70%, maybe 15, 10%. We do a decent job of saving their lives. But out of that 50% that we save, 85% of them are much worse off, much more debilitated, much sicker if they survive that part. And very often those people never leave a medical facility. They're either in a nursing home or a SNP or something long-term until they have another complication, come back and pass away. So again, if you teach that more aggressively, they got 37% of people that changed their living wills in this one study by taking that group and then re-educating them, this group. So education can have an effect, but there's still this huge disconnect because our society tells them that we're great. And you are. I want you to know, each and every one of you, you're fantastic. You are all my physicians. You're great. But there's this misconception that when we talk about the idea of autonomy and informed consent and substitute judgment, we have to know that that's the bar we're facing, whether we're in a clinic here talking about advanced directives, whether we're in a nursing home visiting a patient, whether we're in a hospital taking care of a sick patient. That's the bar you're having to face when you talk to families. So this is an interesting case that was written in chest about 2 months ago. So I want to go through this case and then we'll have time for discussion. The 17-year-old man with metastatic pancreatic cancer came to the ICU, confused, PF ratio oxygen demand was high, probably because he had pulmonary mets. In the presence of his son, his assigned proxy by MPOA and the team, he requested DNR or DNAR and do not intubate status before he went on to lose decision-making capacity. So when that happened, the patient's brother and another son heard of the code status change. They came in, argued with the team, and requested or demanded a change to full code status. Now, the younger son who had been there, who had been discussing with the patient, discussing with the medical team, who was the legal healthcare proxy, and had been present when the patient clearly stated he didn't want any of this, he wouldn't speak back against his brother or his uncle. And so the patient was returned to full code. So this article begins to discuss what happened and what could have been done. And I thought it did some really unique things. So first they talked about, well, what could have happened? Let's think about what's possible. Everybody could respect the patient's wishes. First thing, respect what the family wants, and guy's full code. They can encourage the son, who is the actual proxy for the patient, to respect his father's wishes and keep the patient, DNR, a DNI. You can try to remove the son as a healthcare proxy, which doesn't work, by the way. But anyway, you could think about it. Or then you could actually just respect the patient's wishes. Now, this is as providers for non-escalation of care. And say, the patient said he didn't want it, and we don't care what you say as the family. We're going to stick to what the patient said, by God, and we're going to do what he wants, and we're going to let him die. Yeah. Those are kind of your options in this kind of situation. This article kind of went through this discussion, and the idea that when you are any of these situations, you should think about the decisions from the perspective of medical appropriateness, that is what's right in medicine. What corroboration do you have for the patient in the patient's perspective? What discretion is available? And what is the real purpose? What each person, and I think you all know this, when you go to a meeting, everybody has an agenda. Everybody has a perspective and a reason for why they do what they do. And trying to understand what the different parties' perspective is can give you insight as far as where to go from. And again, the descriptions are medical appropriateness, expected benefit of the patients, therapy outweighs harms, corroboration, surrogate substituted judgment, is plausible interpretation of the patient's wishes, is it or is it not? Patient would have allowed the surrogate authority regarding real-time decisions. That is, do you think the patient would have allowed or would have wanted the son to make a different decision based upon what the son knew rather than what the patient knew? In other words, what is the relationship between the MPOA and the patient? How close are they? How much do they understand each other? Did that patient imply or truly give discretion to that MPOA? And then next thing is that, are you confident the patient really understood when they made that decision? Like, remember the example I used, I was not convinced that our patient really understood what the ramifications of the decision were. Now, that was my call, that was my decision, but I felt that way. Now, again, she did agree, but I did talk to her for a long while, so it was my call. Anyway, so the idea is that if you're going to make any kind of decision based on this kind of concept, when there's conflict, certainly the appropriateness of this, you have to be convinced that your recommendation is truly medically appropriate. You can't have any doubt. Maybe I'm not, no, you have to be certain that what you're recommending is the right thing. It's also necessary that if you're going to go one way or another, that it's necessary to have appropriate cooperation with the surrogates and what they're doing and what they're saying. Now, again, they talk about the idea of discretion. The idea is that, do you think that family member really felt or was given discretion by the patient? That's difficult to actually to ascertain. And then purpose, if the patient really did have clear discretion, like, I want you to make, but I want this, but in the end, I want you to make a decision kind of thing. Husband tells the wife, I really don't think I want this, but if I'm not available, honey, you make the decision, kind of thing. They made that. Then we gotta make sure that, okay, so speaking to that spouse or that family member, again, what did you think your family member really wanted? And if you're going to go against what that family member requested, why? Why? Because a lot of times you get to that point, a lot of times it's that I don't want to see my loved one. I mean, I would tell you 80% of the time, that's the answer. I don't want to see my loved one die. And to finish quickly, but to not take too long, that's not a valid answer. It's really not. I don't tell the patient's wife, that's not a valid answer. I've been talking about, well, guess what? One of my favorite lines, not in this situation, is that life is a terminal disease. We're all going to die. So just because I don't want to see a loved one die is not reason enough to not respect what their wishes were. So what else is there? And be able to talk through them, and find out what's going. And many times, just heartbreak, anguish, and many children and parents, a lot of times it's anger and frustration. There's all kinds of things that play out, and it's important to get those things out in the open, to talk through those things with your family members who are there. And again, these things give safeguards against medically inappropriate treatment or things of that nature. I'll have this will be posted and you can look at it. So the bottom line is that if you can go through these discussions, if you can get patients and family members to kind of come forward with what it is, what their fears are, what their aspects are, and we're respecting what they believe and what they think about, and then place it together with what the patient has said or expressed or whatever, and make sure they understand that first, the patient's request is what's primary. But honestly, if you ignore the family's feelings, you will get nowhere. You have to bring those in and just discuss them and bring them on the open. If you do that, again, the rate of acceptance of DNR went from 53%, went against was 59%, it went down to 29%. In words, 30% of people changed their mind and said, yes, my family member really would not have wanted this. They come to a point of acceptance. They begin to value comfort and determines quality of life over just having people just live. And the true, and what's kind of important, I think, is that they recognize probably, I really don't want my family member to die in an ICU in a bunch of machines. I would rather them not be in that setting, but be in a place where I can hold their hand and hold them and pray for them, whether that's in an inpatient hospital setting, if they can last that long, or in a home hospice setting. If you begin to talk about it in that realm, that really what your family really would want is to love you and be a part of you and be connected to you, not have 8,000 tubes stuck out of them, preventing you from coming close to while the nurses are taking care of the patient on 8 drips and everything else. So it's always this thing of trying to bring, remember we talked about way in the beginning, the idea of the Hippocratic Oath and the whole idea of beneficence, non-maleficence, autonomy, justice, and everything else. It really comes down to seeing your patient as a human being. And what does any human being want? They want to be loved. I mean, in the end, that's what it's about. They want to be loved. And all you want to do is find a way to get your patients and their families to be able to express love to themselves, maybe one last time, whatever that is. And I would propose that sticking tubes and lines and the people is not the way to make your family members be loved. I think holding their hand, singing to them, kissing them, whatever it is that's special for you, especially for the family, is what's important at this time, point in time. If they live a day and a half longer and they don't have that, so that's what I would. So just really quickly, if you have discussions, bottom line, everything gets better. Decreased ventilation, decreased CPR, decreased ICU admissions. And the other point is actuality. So it doesn't cause any more depression or worry because they tested patient families after that. They did, PQ9s and everything else. They go into hospice earlier. If you get more aggressive care, you score them out, decrease quality of life. And after the patient dies, I wish I had more time with my patient or my loved one. I wish I'd be able to hold their hand more. I mean, that's repeatedly expressed by families after the fact. And so the goal in the end of life care is time with your loved one should be the greatest goal. We talk about what is the greatest gift you can give to a patient and their families is time with each other. I strongly believe that. I'm gonna go through this consideration and cautions of life. This is most of you aren't doing withdrawal life. I do a lot of that more than any of you guys. I'm gonna skip past this because also it's too small to read. A lot of you did it. That's what I thought. And again, hopeful disclosure. Patients want doctors to be knowledgeable and realistic, to give them up-to-date treatments, possibilities. They want to know their pains will be controlled. And they want to be able to ask any question. And I've heard some bizarre questions, any questions. They lose hope if you look uncomfortable with death, if you look uncomfortable with injury and sickness. They lose hope if you don't speak to the patient first if they're able to. Again, so you just have the relationship with the patient first, then the family. And I know some cultures don't like that. So that's something you have to deal with the individual culture, talk to those families. And even I use this kind of as a statement to them, we find that patients are much more at peace if they know we haven't hidden things from them, if we haven't lied to them by keeping things from them. Now we use that with some families. I'm never going to override anybody's base culture. But I will try to convince them that in actuality for your loved one, in the end, what we want is peace for them. And the studies show that they're more peaceful. Most patients. Again, don't use euphemisms. Speak honestly. Clear words. Death is a word. Suffering is a word. Pain is a word. It may hurt them, but people in the end want truthfulness. No icing on the cake. Just tell them the truth, plainly and simply. And find consensus on that patient's values, not other people's preferences. So if you can, with your family members, it's great to have family members come in and hear what your patient wants, if at all possible. If there's clergy involved, or especially if you're at the end of life, having them involved. If there's other ministers or other people who are important to them, spiritual leaders. When you do talk to your patients, it really should, in my mind, it's almost always use the physician. Maybe we do with residents, but we have nurses at bedside, but I try to minimize to a close-knit group. Even when I'm, as an ethics consultant, I go in with a family and a physician. I try to, it's us, where it's a safe space. We can talk. You can say whatever you want to say, whether it's ugly or pretty. Let's just say it. If there's too many people, some people feel they can't speak truthfully. Sit down, take time, listen to them, get in a private space, and let them know, hey, you can contact us. Something changes, let me know. So now we're going to talk more about the concepts of ethics. this has been matured over a lot of years. I am frequently asked, should we get an ethics consultant? And I frequently say no, and being one of the ethics consultants, because first thing, I'm a foreigner coming into a strange situation. I don't have a therapeutic alliance with that patient. You know, I don't know that. Therefore, you're their physician. You've cared for them, you know, and or their family member. You know, this is a discussion you should be driving. Will I come in? Yes, but you should be driving this because you have a therapeutic alliance with, you know, with that patient. You understand beneficence, non-maleficence. You understand primum non nocere, first do no harm. It's been drilled into you since day one of medical school. Yeah. And you are just as capable or more capable than any ethics consultant could ever be. Remember, sometimes your ethics consultants don't really practice medicine more. We have some very good ones who do, but some of them don't anymore. They become bioethics, I don't know, gurus or whatever. And these people, you know, scare me. Like, you know, it's just, you know, people who do care for a living should be caring at the end of death, end of life as well. So autonomy, substitute judgment, again, and by mind, finding that place that our patient can be served the most by what we do is what's really, really important. So thank you for hearing me rattle on. I'm willing to take some questions or comments. I think this will be available. It's like 2 references. If you want to read a bunch of readable on other kind of sociological journal discussions on other conflict and ethics things. But I do want to say, you know, again, I'm an intensivist who works in the family medicine residency program. This stuff flows from the clinic to the hospital. You know, again, you know, what do you guys say? You know, from the cradle to the grave, you guys take care of your patients, you know, across the spectrum. These things, these are truths that are kind of universal and are applicable to, you know, to all your patients at one time. Informed consent, but even where I live with life, it's still informed consent. It's just therapeutic alliance. It's personal. You know, I want the best for you and your family. That's really all in my mind. That's what that is. The rest of these kind of moments, you have to write so they can get their money and get right books. Thank you. Any questions? Yes, please. I don't. You know, each person, you have to kind of find your own way forward. The easy answer is that all of us, right, all of us have some form of compartmentalization. We all do. Otherwise, we wouldn't survive, right? But I think there's some degree of when you're facing a difficult situation, there is immediate compartmentalization. You have a job. Your job is to take care of that patient and the surrounding issues involved with it. If I am so emotionally broken that I can't do that, then I have to tap out, and that has happened. Tap out, need someone else to take over. Really, I am too involved with this care for this patient to take care of me. Okay, and guess what? That's okay, and you should recognize if that truly happens, you should tap out. Okay, and defer and get someone to help you take care. That's really uncommon from most conditions, but there's sometimes it does happen. But the whole point is that you really do, and as I said, I really appreciated the pit. I'm gonna say that again, because it did deal with that issue about how these things impact and how I tell you, almost everybody who went through COVID, you know, I'm sure there's a little bit of PTSD there for everybody, things that none of us that we haven't fully dealt with. And so, guess what? Some things you probably will never deal with, but whatever you need in that, you know, whether it's sitting down with a friend or a colleague, sometimes that's enough, you know. Decompressing, you know, we very often will debrief after a code or after that situation. For a lot of people, that's enough. If you need more, counseling is totally appropriate. And, you know, to try to talk through these issues. Sometimes people get triggered because we see something that's very related to something that happened in our lives. And it delves into a deeper issue that doesn't get handled in a debrief or discussion with a colleague or a mentor after that. So, Yeah, each of us have to find our own way forward in that, but those are techniques that are there, again. I very often will sit and talk with somebody. Some of the family members, sometimes with someone at work, and we just talk it out. And for me, first I'm thinking, did I do something wrong? There's always that question in the back of your head, right? Not do the right thing? And then after that, it's like, walking through that with the person. And then if I'm good, fine. There's sometimes something will pop up from 10, 15 years ago, pop up from last week. I think that's kind of part of medicine. We carry a lot of things from our patients and their families, and they trust us to carry. Fully. Sometimes professional counseling is needed, fully, and you should feel free. You should want to do that, so you can keep giving that kind of supportive care to your family and your colleagues. Yes, sir. Mhm. Well, yeah. So if you notice, I mean, a lot of us, when we fall back on that, and again, those of us with experience, we know very often we know the end of the story. We know the end of the story. The family and the family members can't see the end of the story, but we know. Now, are we wrong? Sure, every 1 in 100, 1 in 200 times we're wrong, but we know the end of the story. So you're right. We cannot rush. The point you're saying, you cannot make the story rush to the end. You can't force the story to rush to the end. So in this case, guess what? No, they didn't. So they, again, like I said, they took time over a 3-day period, met multiple times with the family, began discussing and always emphasizing, what did your loved one want? This is what he expressed. Saying things, right now, it's not what he wanted. Using the term that I think right now for him, spiritually and emotionally, you can consider what he's going through right now as suffering. Those kind of discussions with the patient and their family. You're right. So I'm not going to say, let's just futile, I'm going to pull it too. That day is long gone. That did happen in the past. I'm not saying someone doesn't do it now, but you're right. I mean, technically, you could argue right now that would technically be illegal. That is technically illegal, at least in the state of Texas. It's illegal. And I mean, you are literally breaking a law if you do that. So it really does come down. And again, if you are convinced you want to do that, you're talking about at least a 35-day period at a minimum of getting from what you think is right in an adversarial situation to get to the saying, well, I'm gonna have my way, this patient student is gonna be pulled. It's not working. It's just not gonna work. So, and sometimes I'll say, is there someone else who maybe this family will respond to better? Like I said, a clergy member, family pastor, priest, imam, minister, whatever. Is there a different family member who understands, is bringing the whole family in? All those things are kind of tools you use, to say, and the point I try to make is that I try to be careful not to try to get the family member to feel like you're trying to convince me to kill my loved one. Because that happens. People feel that, right? And sometimes, I'll be honest with you, that is what happens. Everyone's convinced this is futile care, doggone it. We're going to make you understand that in my experience, in my perspective, that doesn't work. Again, understanding why those family members are, my comment is, why, I don't say this words, but in my back mind, why are you so afraid of death? Things pop up. I've had family members who didn't want this to happen. Why? Because they were living off that patient's Social Security check. Didn't care anything about the patient. They were getting money. That's hard to crack. But guess what? I remember it took about 7 days, but we cracked that by taking time, spending time, even trying to find this person resources, doing things like that. Why is it that they're so against what they're loving? You have to get to that bottom of that egg. And if you take the time, because again, you got a 35-day window. If you start today, I don't think this is right. You gotta, and you're doing it for the very purpose of saying that I think we should let this patient die. That is withdrawal of care. It's a minimum 35-day period in Texas. I guarantee you, we spend anywhere from 3 to 7 days with that family trying to understand where they're coming from and what's going on. You're far more successful. And plus in that time, guess what? That patient will deteriorate. They begin to see more and more that this really is not what they want. 99 times out of 100, they're seeing it is really harmful to their level. There's always these weird people like money issues or that kind of stuff. There's a couple of issues where they actually wanted to see their family member suffer because they had such a horrible life and whatever, and they wanted their father to suffer to the end. That was the hardest one to crack. That was the hardest one. Yeah.
So, legally, in your case, we're not proximity. We don't know. Let's say, yeah, even though having so patient now intubated, and the family goes, oh, wait a second. This was a terrible idea. So take it all back there. What's that?
Oh, it doesn't take anything at all. I get them, I confirm, having witnessed that in the United States and in Texas, informed refusal or informed dissent, I do not want this procedure done. Withdrawal of care is equal. It's legally the same. So if you have a procedure that's done or something that's done and you don't want it done anymore, you're essentially making now informed consent to remove that procedure the same way you agreed to have it put in. So it is just really, again, making the patient make sure they do not resuscitate. You document that. In fact, so what we have are what we call POST, or patient-oriented and life-sustaining therapy orders. And almost every hospital has that in the LSU. It says, patient does not want, do not escalate care, yes or no. Do not intubate, yes or no. Do not use non-invasive ventilation, yes or no. Do not use vasopressors, yes or no. Yeah. So you can go down and say, do not do dialysis. And you can actually go to that and you get to the end of the point. Well, gee, that means you don't want anything done. We're going to stop doing all these things. And we're going to stop. We stop. Look. Mm-hmm. No, literally, it takes, hate to say it, half an hour. Make sure everything's like ducks in a row, make sure that everyone agrees, document, you got a witness document that it's not, and they don't sign anything. They verbally tell you and the healthcare, and again, it's that interesting thing about Texas law, whereas again, you have to have all these outside witnesses for a patient to tell you, for a proxy. It can just be you and the nurse. I mean, or you and another family member. It's not these people who have to be totally I don't understand it. Disassociated from the care. So you document this is not what the patient wanted. You write nice note, write an order, and I go in, stop the vasopressors. I ask them, do you want to be in the room when the tube gets taken out, or do you want to be out of the room and have to come back in when the tube's taken out? They say one way or another. It's your choice, whatever you want. We take the tube out. Very often, if it's common care, very often we start them on a morphine drip. I don't normally push large amounts of morphine, get like 2 milligrams of morphine, so I'm on a morphine drip, because very often they're going to, depends on what the patient issue is. I want them to be comfortable. And again, remember one of those questions that they always ask is my loved one's pain going to be accommodated, taken care of? So routinely, unless, now there's sometimes this happens when the patient is actually already in the extremis. And I hate to say this, there is this factor in the law about when two physicians really agree that a patient is in extremis, you can stop care. I have never seen anyone use that phrase, because again, who's defining extremis? Is it when the blood pressure is 50 or 30? Is it, it's like you get to this kind of, it's just too difficult. Normally, and that patient's going to pass away anyway, right? Because the pressure is doing this, right? Same thing. So you do it, and the family comes back in, and the patient lives 15 minutes or lives 15 hours or whatever. And if they take longer, we normally move them up to a regular room out of the ICU. And we actually then at that point contact hospice. I normally don't initially, we actually do now because the hospital wants to, but initially I would only watch that patient for 2 to 4 hours. And only if they look like they're going to last more than a few hours, I would then contact hospice services. Now we kind of do it by routine just because that's what they want us to do in our facility. And most of these people pass away within 6 hours. There's a smaller group that lasts a day or two. And that's kind of, and I just so I keep the patient comfortable. And that's clearly spelled out. Withdrawal of care is no different than refusal of care. Other question? Yes.
Forms that without being gone, recommend having statement.
Yeah, so I mean, a lot of people have electronic, right, mental health records now. You can still have a template, that's, and you can say this classic, all responsible for important risks and benefits of the patient. I would normally specifically spell out what complications I told the patient. Some people don't like that. Say, well, you leave yourself open to, and tell them again about the orange toe. At the end, you know, I'm just going to trust her. I tell about the things that are life, eyesight, you know, skill, threaten. Those things I want them to know about. And I normally say yes. We discuss with the patient fully understands. Yeah, there are plenty of examples. You can even Google an example of standardized risk management. Again, in Texas, if it's you need to look at the idea of the list A and list B procedures. Most of those are inpatient. There's some things like that happen at ambulatory surgery centers. Those things, they're just basic procedures. They're in groups. There are things that they're actually forms. There's actually requirements. You have to say, I discussed these complications. There are other complications, and you can even add, I also discussed these other complications to it, you know. But and like we're in Epic now. Epic has the consent tab, and actually it's all there. For those procedures, a lot of procedures that we do though are not there. Like there's not much skin biopsy, things of that nature. So you should talk, discuss the possible risk, that kind of thing. Most office procedures are not in that list. But you should, you know, say these are the common risks that we think about when we. You're implying, so like, yes, you're implying by you as a physician signing on to that consent form, you have essentially said the patient has capacity to make a decision. Because that's what if you go back to the, you know, yeah, what you're saying is that you did these things and the patient had capacity to make that decision by signing that form. Okay, so first thing, remember I'm an adult doctor, but I have kids. And that really comes down to, you know, your interpretation of the situation. I do think you want to avoid trauma to any child. You're right, it can have repercussions. So what else can we do, or how else can we do this? You know, if it's really necessary, you know, like an interesting thing. So it's like my wife and I work a lot with Morgan's and Mac. And they have an interesting clinic because, you know, a lot of disabled children really have trouble understanding everything. I'm trying to remember the name of the clinic. They have a clinic where they will fake walk the kids through procedure, even like drawing blood. So they have toys and stuff. And they sit the kid down and they walk them through. This is what's going to happen. You're going to feel this. And I mean, it's a great concept. You know, how can I remove the fear? And so when I say kids, sometimes these are adults, but you know, their brain powers, they're 3 or 4 or 5 year olds. And they will actually take time. They'll have an appointment for, you know, like, let's say a kid has to, let's say even has to have like their moles taken out next week. They'll go into that clinic the week before and they'll walk them through what the procedure is with, you know, with tools and toys to try to get rid of some of that anxiety, some of that fear. It's not perfect, but that kind of thing, you can look at things like that to help get them through something. And maybe it's that, maybe the procedure is not so mandatory to do it now. Let's come a way to try to make this child more comfortable. Clearly, It does happen sometimes. There are exams on anesthesia, we really prefer not to do that. But that's, in the end, if something has to be done, that probably becomes your end all be all with the family's consent. I guess that is some anesthesia. But that should be a real last resort if you can all avoid it. All right, well, thank you.